Okay, we're going to go ahead and get started. So good morning, everyone. Thank you for joining us this morning at Live. So excited to introduce this morning's speaker, someone that we are all very familiar with and have worked with her, that we love. So I'll be introducing Dr. Samantha Anne. So she's currently the medical director of pediatric ear and hearing disorder here at the Cleveland Clinic, and now a full professor in otolaryngology, head and neck surgery at Cleveland Clinic Lerner Medical School. And so she's been one of our staff here in pediatric otolaryngology. And, she comes from Michigan, where she completed her medical degree at Wayne State. And then she completed her residency at University Hospital and did her pediatric otolaryngology fellowship at UPMC Children's Hospital, Pittsburgh. So we all know that she's a very well-known national and international leader in the topic of pediatric hearing loss. She's been in a lot of leadership positions in national societies and has a very impressive CV. And, for many of us here, she's been a phenomenal colleague, teacher, mentor, and a dear friend. And so we're just so lucky to have her here. And so this morning, she'll be speaking to us on the topic of unilateral hearing loss in children, where she'll be giving us a comprehensive update on the management, including outcomes of cochlear implants, as well as quality of life outcomes. So thank you so much, Dr. Anne.
Thanks, Jamie. All right, everyone. So thank you so much for the invitation to do grand rounds. And, I get super excited when I start talking about hearing loss, and I can go on all day, but I did my best to try to dilute all the information into this package. And my hope is to tell you a story about what happens when a child comes in with a hearing loss, and start from the, start to the finish, from diagnosis and trying to figure out why they have the hearing loss all the way to the end in terms of management. What do you do with them? Unilateral hearing loss is common. If you look at the overall incidence of hearing loss at birth, it's about 1.86 out of 1,000 newborns in developed countries, and 30 to 40% of those are unilateral. Now, those are congenital. So when you start adding in school-age children, the rate goes up to 1.5%. In the NHANES survey, which was in the 1980s, the rate went up to 14.9% of the children around 12 to 19 years. In the most recent survey, 2005, 2006, the rate is 20% having hearing loss in at least 1 year. So although this talk may not be so relevant to some of our practices, I'm hoping that this will still be relevant to your lives. Not hoping, but it might be relevant to your lives, because 1 out of 5 children have some sort of a hearing loss. And you may know a colleague or a family friend who has a child with a hearing loss. So with that, we will talk about the impact of unilateral hearing loss, etiology, looking at the evaluation, looking at the reason for imaging, genetics, labs, and then the management. Specifically, we'll talk about hearing aids, when to use bone anchored versus cross. And then CI, I'm going to spend a significant amount of time at the end, because this is the latest, greatest tool that we have to deal with pediatric unilateral hearing loss. So we will look at some variables that impact outcomes with CI, and then look at quality of life outcomes, and look at candidacy considerations, and then overall outcomes with all these management options. So why do we even care? It's one side. You put them in the front of the classroom and put the good ear to the teacher, right? That's what we used to say. Well, not quite the same. We feel a little bit differently, because we know that there are benefits with binaural hearing. The head shadow effect is when you have a noise coming in one ear, you have the good ear on the other side, and the sound, the noise getting attenuated over the head is helpful, because then you have the good sound on the other side. However, if you have the hearing loss in the good ear, and then you have the noise in the other ear, we all know that children decompensate when you start adding noise and you have a poor hearing ear. And that's where this head shadow effect is pretty hurtful to these children with unilateral hearing loss. A squelch effect. If you add 2 ears, you have the benefit of adding the ear with a poorer signal to noise ratio. And then the summation is you give 2 signals, all of a sudden this loudness just goes up by just pure addition of that second ear. And then sound localization, knowing where the sound is coming from. So the impact of unilateral hearing loss. Judy Liu did a lot of this work early 2000s, and she formed the basis for a lot of what we know about unilateral hearing loss. She published a systematic review of putting together everything that's out there, and she found that unilateral hearing loss has increased rate of grade failures, and these children need additional educational assistance. There's perceived behavioral issues in the classroom, and then there's this question of possible delay in speech language development. So we looked at this a little bit further. We did a systematic review of all the literature that's out there, looking at speech and language outcomes in children with unilateral hearing loss. And this is about 4 or 5 years ago. And at that point, there were only 13 studies that looked at this. So this is not studied enough and is becoming more and more of an important topic, because we're realizing that even with one-sided hearing loss, these children are impacted in scholastics and speech and language and developmental milestones and everything else. Nevertheless, out of the 13 studies that they looked at, 7 of them showed poor scores, and these are listed here. And then what is clear is that these effects are much worse with severe to profound hearing loss. So the etiology. So we had a couple of studies that came out of our institution, including a multi-institutional study done by Janke, and that was in 2018. We looked at all these children with the unilateral hearing loss and the cause of it. And in about half the children, we never figure out why they have the hearing loss. We do know that about 10 to 15% progress to the other side. And then the most common causes are the inner ear anomalies. Cochlear nerve deficiencies is about 26 to 50%. And enlarged vestibular aqueducts, in our study, we found 23 to 41%. This table is from Judy Liu's paper, review paper in 2015. For some reason, the EVAs are not included in that. So, we put it in there. Almost equal incidence of both of these within these population. Then there's the addition of the perinatal insults, the torch, the CMV infections, meningitis, and genetic causes add up to the rest of the causes of these hearing loss. So with that etiology in the back of the mind, what do we do for these patients when they come in? So this is the JCIH recommendation, so 1, 3, 6 months that we've heard in the past. Well, it's now encouraged to be the 1, 2, 3 months. So I'm going to highlight this part that's circled and that's brought up into this. So the most important thing is that, the audiology and the otolaryngology aspect of it is definitely absolutely required. And then if you look at what other things are required, the otolaryngologist is required. Ophthalmologists and geneticists are recommended. And then all the other things, the developmental piece, neurology, cardiology, are as needed. So this is what it comes down to, right? For all hearing loss children, this is what's recommended and required. So let's look at this. Why do we need ophthalmology? So there are genetic disorders, even with unilateral hearing loss, and vision disorders. And if you remember me saying cranial nerve deficiency is one of the most common reasons that children have unilateral hearing loss, and about 2/3 of them have ophthalmological disorders. And this unilateral hearing loss has vision issues with Waardenburg syndrome. And then we know that if you already have a known hearing loss and then you're adding the vision issues on top of that, this is just adding to the communication difficulties for the children. We don't need them to have 2 hits. And then a lot of these children do have something. It might be just something simple like needing glasses, but almost 2/3 of these children that we refer to ophthalmology come back with some kind of a diagnosis that's impacting them. So ophthalmology, I know it says recommended, but in my book, it's required. So labs, well, the shotgun approach, not recommended, not useful. This is Marley Kinne's landmark paper in 1999 that she published, and she looked at 301 patients with hearing loss. And since then, there's been a couple more papers that came out looking at what's the value of getting all these testing results with TFDs, UAs, labs, and all this stuff. And as you can see, all of them are low. It's not worth just doing all this random lab work. But what is high yield, if you see my arrow, is pointing to CAT scans and MRIs. So genetic testing, we're going to talk about imaging in a minute, but genetic testing. So unilateral hearing loss is a little bit more of a question mark if they really need genetic evaluation. They do. So there are some syndromes that can have unilateral hearing loss. I mentioned Waardenburg in the past. So single gene sequencing for that is helpful. If you want to look at the whole genome and whole exome sequencing, those are options. And then, Haffey et al., this is one of our residents in the past that published this paper. There are syndromic causes of unilateral hearing loss. So for these children, doing phenotype-based diagnosis or microarray targeted sequences is helpful. So genetic testing, although in bilateral is critical, it becomes more questionable, but in my book also seems to be very helpful in trying to figure out where the hearing loss is coming from. Imaging, absolutely, yes, high diagnostic yield. And the timing of the imaging, well, if you're thinking we're going to need a CI, early is helpful. So, consider with the repeat ABR, because MRIs need sedation usually. We started, based on this study from Ronner et al. 2018 from Mass Eye. They published a study looking at sleep MRI, where the infants, they're less than 6 months, they starve the baby, don't let them sleep, much like they do to us. And then you give them this massive meal and they sleep. It's like post Thanksgiving turkey meal, essentially. And they sleep through this MRI. And the sleep MRI was successful in 61% of these cases. So we started this here at the Cleveland Clinic, and I do it up to 3 months, and almost every single one is successful. We've been able to get results with just a sleep MRI in almost every single patient within 3 months of life. And now we have the information we need to kind of build the management plan over the next few years. How should we image? Well, the benefits of CT, we know it's fast, it does have radiation. Well, the MRI is great, but then you'd probably need sedation unless they're older. So which test is better? Well, there's no right answer. So our multi-institutional study that I mentioned that Jackie did, there were about 200 patients. They underwent CT and or MRI, and there was no difference in the number of findings we found in these patients. So MRI, the rate of positive findings was 42%, CT was about 37%, and that was not statistically significant. Interestingly, the CT, as you expected, showed the EVA to be the most common diagnosis. MRI showed cochlear nerve aplasia. So again, those two keep popping up as the two most common diagnoses, and depends on what imaging study you're doing. And, when you think about what's the more likely to be etiology, the studies that came out of our institution keep suggesting that EVA is the most common. And then there's a couple of studies that came out of Cincy that suggest that cranial nerve deficiency is the most common reason. So this systematic review that looked at all of this in 2019, the diagnostic yield is about the same, about 37%, 35% for CT and MRI. And if you look at cochlear nerve deficiencies, for some reason they recommend, the CT picked it up more, although overall they're about the same. So it's a toss-up, right? Well, I think we can make some recommendations based on what we know. In general, if they're little and they're less than 3 or 4 months, or they need a CI for unilateral hearing loss, MRI is absolutely the right answer. With cochlear nerve deficiency, cochlear implant is no longer an option. So knowing that is critical if the child is on this path to getting a CI. So if they're young and I can do the sleep MRI and avoid the sedation, absolutely, that's the first test I'm going to do. And if they need a CI, absolutely, MRI is the first test I'm going to do, because I want to make sure that that cochlear nerve is robust. If you miss that window or they don't need a CI, there's then this, up to age 7 or 8, you can get a CT because they're able to sit still for it. After about age 4 or 5, they should be able to sit still for it. But after age 8 to 9, I would recommend MRI first, because you don't have to sedate them. Most of them sit still for it, and then you can avoid the radiation. So management. So let's move on to what do we do once we figure out they have this hearing loss? Well, baseline, I recommend all children to get a speech evaluation, and then audiology evaluation for hearing rehabilitation options. And then we have a few tools, but for these children, the hearing aids across, the cochlear implant bone anchors, and then all hearing loss children should get FM systems. There's no reason we shouldn't be helping them at school, having increased access to sound. How do they do with these options for management for hearing loss? So Apache, our own Dr. Apache, did this systematic review in 2017, looking at auditory outcomes with all these options. And there were only 5 studies that looked at, again, this is pretty recent, this is about 5-6 years ago. And there were only 5 studies that looked at hearing aids and cross and FM systems. And overall, all 3 of these, the hearing aids showed some improvement in speech. FM systems showed some improvement in speech rec, and the cross had some variable outcomes. And then there were 7 articles that looked at bone anchor devices, and almost all of them showed improved pure tone averages, speech recs, and sound localization. What about CI? Coming up. So let's actually break it down now to mild and then severe to profound. It's not a sharp division of mild versus severe to profound, but let's break it down for now, and then we'll talk about those middle ground kids in a little bit. So starting with mild hearing loss. Is the hearing aid needed? Well, I would suggest that it doesn't hurt to have a hearing aid. Chenge published this paper out of our institution looking at 50 children with mild, moderate unilateral hearing loss. And she found almost a quarter of these children had a speech and language delay in comparison to general population. And that was statistically significant. And if you think this could be a selection bias, yes, possibly. I recommend all children with hearing loss get a baseline speech and language evaluation. So they're all getting referred, but it is possible that the ones that actually had the speech and language ended up seeing them. However, that is a sharp contrast between general population and speech and the unilateral hearing loss children. There is some concern that there might be increased deficits with these children. Looking back at Swati's paper, there were 2 studies that looked at mild, moderate UHL, but both of them had hearing aids. However, it suggested that with the hearing aids, there is improvement with the child score. And then one study looked at objective outcomes, looking at hearing noise and sound localization, and they did better. So these children with mild hearing loss do look like they're going to have speech and language issues and some other concerns, and they do look like they do better with their hearing aids. So we took this a little further. This was actually a study that we did with Mass Eye and Ear in collaboration, and it was just published in the Laryngoscope last year. We took some children, we started on with just sitting in the front of the classroom in the FM system for the first 12 weeks, and then we gave them a hearing aid for the next 12 weeks. The second group got hearing aid and baseline accommodations for 12 weeks, and then we took away the hearing aid. And sure enough, there were definitely differences on scores on quality of life studies and listening difficulties and challenges with hearing aids, specifically the child and life R that we did. The hearing aid patients did better, and they liked their hearing aids versus just doing the baseline accommodations. So in other words, hearing aids seem to help even with mild unilateral hearing loss. So this is a 6-year-old male presented after failing hearing screen at school. The audiogram showed unilateral mild, no speech and language concerns, no perinatal insults, no family history, completely healthy. So things to think about with this one, this child is completely fine, has no speech and language concerns. He's 6 years old. What kind of imaging would you do? What are you concerned about etiology? Well, you have to start thinking about late onset or progressive causes or sometimes acquired causes of these hearing losses. I do send them to ophthalmology, like I said, did recommend genetics. You have to think about CMV. At this point, you check CMV to rule it out because it's too late to rule in CMV. Congenital CMV can only be diagnosed within first 3 weeks of life. So you check the CMV. If it's not the cause, then we know it's not the cause of this hearing loss. And CMV is one of the more common progressive causes of hearing loss. So acquired, thinking about trauma, ototoxicity, and other things. Management, these children, like I said, I do send them for baseline communication of speech evaluation, FM system at school. And the question is, should we do close observation, monitor speech and language, or should we do a hearing aid? I do fit him with hearing aid. So he was old enough that parents were wanting to know what's wrong and why, this child has a hearing loss. I referred him for evaluations, got the CT, it was normal. And I said, well, let's wait until he's a little bit older to get an MRI. We looked at the findings on either study when you do the other study first, and we found that these studies are picking up other findings that the first study missed. So if you get the CAT scan first, MRI is picking up other things that the CAT scan missed. So we do recommend starting with one, and if it's normal, following up with another one. So this one we fit with the hearing aid and got an FM system in school. And some would argue you put a mild hearing loss children and unilateral hearing loss, and you're putting a hearing aid on them. What's worse, hearing aid on this mild hearing loss or the social stigma I would say that it's becoming very commonplace to get hearing aids. We see it in classrooms, we see it in children wearing it out and about, and even socially is becoming more acceptable. And most recently, there's the American Girl doll that was released with hearing loss. So I think the stigma that we used to have wearing big, Coke bottle glasses when we were growing up, and those kind of things is becoming more and more acceptable, even with hearing aids. What about profound intervention? Absolutely, definitely. There is no question that children with unilateral severe to profound hearing loss have overall worse expressive language scores, lower full scale verbal performance IQ. There's no question that these children are impacted with profound hearing losses on one side. And they, bringing up Swathi's paper again, they do well with bone anchored, but what about CI? I've been teasing this for a little bit, so let's look at that. So this was a systematic review that we did in 2021 that was just published, and there were only, of all the studies that are out there, there was only 120 children that we could look at. So again, all this information is just coming out. We're just starting to learn a little bit more about what this really means for children. And CI for unilateral hearing loss was just approved within the last couple of years for children. So again, more and more evidence is coming out. So in this systematic review, again, looking at 120 children, almost every single one did better with sound localization and outcomes. And then this was one of the best studies that I think I've seen on this, came out of UNC by Kevin Brown. They took 20 patients, at least moderate to profound hearing loss, word score less than 30. And they were all 3.5 to 6.5 years of age. And then they looked at speech perception, noise, quiet, sound localization, and SSQ, which is quality of life study. And they found that CNC improved 1% to 50%. BKB SIN improved in all three noise configuration. Localization improved. And then the SSQ showed improvement. So this is our multi-institutional study that we just submitted for the White Journal, but looking at it with Iowa and Virginia Mason, Seattle, and us, we had about 40 children, and the mean age was about 8 years. Mean duration of hearing loss was 5 years. These children, on average, were using it for about 8 hours a day. And the mean auditory testing scores, Baby Bio was about 68%, Whippy was 52%. CNC, which is the hardest test probably out of the three, it was a little bit lower, about 38%. And usually we say about 50% is the cutoff where we say, okay, they're getting benefit or not. And the scores more than 50% were achieved by 60% of the patients. And then the SSQ scores more than 6 points is considered pretty good. And almost 90% of these patients achieve those scores. I do want to point out that the children that we included in this were all duration of unilateral hearing loss and all ages at CI, up to, I want to say, I think 12, 13 was like the, I take that back, sorry, the ages were all over, but the duration of hearing loss was up to 12 years, I'm going to say. So candidacy. So who do we implant in these children with hearing loss? So the FDA clearly says 5 years of age, unilateral severity profound. Well, there's a little bit more to think about. So cranial nerve deficiency, not a candidate. You do not want to implant a hypoplastic nerve because now you have a good ear and then you have noise and junky sounds coming from the implanted ear and it's just going to hurt the child. This is an absolute critical no. And this is where the MRI comes into play that we talked about earlier. So cochlear anomalies, the key thing is that you just need enough cochlea to get a full electrode insertion to get good outcomes. So, this was a systematic review that we did, and we published this in just last year, actually, looking at all these Mondini children and EVAs, and all these children, even with the 1.5 turns, not the full cochlea, their outcomes were pretty comparable with children with normal cochlea. So they do fine. As long as you can get the electrode in, full insertion, usually you get pretty good outcomes. So at risk for hearing loss in the better ear definitely pushes me to move more aggressively. If we know they have a congenital CMV, or if they have bilateral EVAs and they have a hearing loss that meets CI criteria on one side, there's a good chance the other ear will go at some point. And if that's the case, you want to move aggressively in the deaf ear and get that CI in before we lose that opportunity in the other year starts to go down. Psychosocial factors. So this is not in the official criteria, but you have to think about the family support and child motivation, especially in those teenagers. If they don't want it, you can force them, and the parents will sometimes force these children. But the minute they get to school, they're going to take their implant and throw it in their bag. So you cannot make an older child do it unless they're motivated and they're on board. So this is something to keep in mind with these older children, especially. And this is the question mark. The duration of deafness and age. Is it 4 years, 7 years, longer? Quality of life outcomes. These two we're going to focus a little bit on over the next few minutes, because these are the questions that we don't know quite the answers for. So when you look at the studies that are out there, there's some studies that say there's no benefit when you have long duration of deafness and older age. Essentially, I think of it as if you don't use your muscles and persons like hospitalized, they're on a hospital bed for years and their muscles are completely wasted away. They're going to be puny, and it's really difficult to make it get stronger, versus a person that's been hung up with a fracture for 3 months. It's pretty quick to get them back on board and using their muscles pretty quickly. So little different, but similar concept with the nerve. The longer duration of deafness and the older age, there's a question of, is their outcome going to be just as good? So these two studies suggested there's no benefits if you wait too long or you wait till they're older. But if you look at the numbers, Roche et al. In 2021, there were 11 kids. And they found that the scores were the highest when the children were under 3, and greater than 5, they said there was no improvement. Arendt et al. In 2015 looked at 13 postlingual, 3 perilingual, 4 congenital, and then the longer duration of deafness was associated with worse auditory outcomes. Then there's these studies that said that there are benefits to longer duration of deafness in older age children. So Zeitler et al., again, small studies, 9 children, duration of deafness went up to 10 years. Most of them were users, and they noted improvement on speech rec. Ehrman Mueller in 2027 children, 3 to 16 years of age, they found improvement in speech rec and sound localization. Thomas et al. In 2017, same concept, 21 children, congenital SSC, CI at 10 months, up to 11 years. And they found improvement in SSQ, and this is the quality of life measure. And then interestingly, they said there's no differences between CI at less than 6 years versus greater than 6 years. So a little bit of a question mark about this. So let's draw a hard line, right? Let's aim for 0 to 4 years, because those kids are going to do well. If they're less than 7, let's move forward, settle for it. Let's just do it. But let's start thinking about it a couple of times about if you really want to move forward when they're 7 to 10 years. And then look at other options after 10 years, because after 10 years, the chance of getting outcomes seems to be a lot more questionable. Except it's not that simple. And what are you talking about, right? So let's look at this. So duration of deafness and age consideration. So this is the multi-institutional study that we were looking at. And we looked at the association between age as CI and duration of hearing loss versus auditory outcomes on these CNC, Baby Bio, Whippy, and we found no correlation, meaning it doesn't matter how many years of deafness they have or how old they are. It's not correlating to the outcomes one by one. So these measures are all over the place. So I don't understand what's making the difference, right? And that's the question mark. And we think there's more to it. So the quality of life consideration. So this was our study that we just published in the White Journal. And we did the Children with Cochlear Implants Parental Perspective Survey. It has 8 domains, and we compared how the quality of life outcomes look with these children with unilateral hearing loss in comparison to bilateral. And then we split it up to duration of hearing loss less than 7 years and greater than 7 years, and by age, to see if the health-related quality of life benefits were a difference between them. And this is a breakdown of the children. So when we looked at unilateral versus bilateral, they all did great. They all had pretty similar outcomes. There's no statistically significant difference between the quality of life benefits, and 3 is the cutoff where there's a positive outlook to CI, and almost all of them, whether the unilateral or bilateral, ended up in the positive side. When you looked at not prolonged versus prolonged hearing loss, again, they're all within the positives. And I think there were only a couple of domains where there were statistically significant difference between unilateral, bilateral, but not prolonged and not prolonged. So candidacy determination is not that simple. You have to think about the age, the years of prior device use, and the quality of life benefits, motivation, etiology, auditory testing, psychosocial support, and others. So there's no clear answer, in other words. So looking at, this 3-week-old infant, failed newborn hearing screen, ABR, showed right normal hearing, left profound, CMV was positive. So considerations for this case, you have to know that this is a baby with congenital CMV. You have to think about the other sequelae and then the long-term follow-up for this baby. So opto, absolutely. Genetics, it's a question mark. The 2-hit theory, could they possibly also have a genetics insult on top of the CMV? Possibly, but I'm less forceful with this one. MRI versus CT, you can go either way, but MRI, we're also looking for neurological concerns. So, either image, we should be thinking about the brain. ID consult to think about treatment, neurology to evaluate for these neurological disorders that we talk about. CMV is the most common congenital infection. This is why it's important to know this and think about this. 1 to 4% seroconvert during pregnancy. About a third of them give it to the fetus. About a third of them reactivate during pregnancy. About a third of those, or 1 to 3%, transmitted to the fetus. 1 in 200 children are born with CMV positive. Very, very common. And it causes hearing loss in 10 to 15% of these cases. You have other symptoms, microcephaly, developmental delays, seizures, and it's the most common non-genetic cause of deafness in the US. But the hearing loss is only if it's acquired in utero. So it's so common. Like I said earlier, after 3 weeks, it's not useful to rule in anymore. It's so common that you can pick it up postnatally, and that doesn't cause a hearing loss. So after 3 weeks, it's not helpful. And what drives me crazy is that there's no universal screening for CMV, but then we're testing for carnitine uptake and tyrosinemia, and I've never even heard of these things. So just on the soapbox for a second there. Nevertheless, so antiviral treatment for symptomatic congenital CMV absolutely shows improvement. This was a study in the New England Journal of Medicine. They tested ganciclovir versus ganciclovir at 96 neonates, 6 weeks versus 6 months. They found that it can stabilize or reverse hearing loss. And these are symptomatic congenital CMV children. But they said the treatment has to be early to be effective. The treatment's not totally benign. So gonatotoxicity has been shown in animals, not shown in humans. However, it is something that should be in the back of the mind to think about. Neutropenia is something you worry about in patients. And then management, this baby that we were talking about did get treated, found no difference in hearing. We tried a soft band at 3 months, very motivated family, well tolerated. And then we talked about the CI and, sent them for a baseline communication speech eval. So in the pre-op audio, you can see the left ear is completely done. The right ear is, close to normal. After CI did great. I think I do want to point out, as we talked about, this right ear is starting to drift down as well. So this is exactly why we need that left ear rehabilitated, because if the right ear starts going down, which it can with CMV, now we're not stuck with 2 deaf ears and, trying to race time to get those in before the baby starts to have deficits. This is a case where, if you remember me saying, well, it's not a sharp divide of mild, yes, they need hearing aids, severe to profound, they need CIs. There's those in-betweeners where their hearing is good enough, but not to meet criteria, but then poor enough that they're not getting enough benefit with a hearing aid, and they're stuck in this in-between. So this is a 10-year-old that I took care of, failed hearing screening at school. Notice, parents are noticing that he's asking people to repeat themselves, they're concerned for ADHD, having difficulties at school, and the remainder of the history is completely unremarkable. Healthy, CT MRI was unremarkable, optogenetics was unremarkable, and this was his hearing test when he first came in. So we, used the hearing aid for a little bit, and he did great, and then disappeared. Came back 7 years later. because he wants to try the hearing aid once more. So we got the audio, which looks similar. However, if you look at the word rec, it's down to 28%. So we did a CI eval on this patient, deemed a candidate, and then we had a full discussion. He was actually on board and eager to get the CI. And again, these teenagers are those, you have to make sure that they're motivated to get it as well. And he was eager to get it before going to college. So we did. Pre-op testing, shows you pretty poor CNC words, and AZ Bio looks pretty poor. SSQ, the score is less than 6. If you remember me saying that less than 6 is usually not that great. So uneventful CI, saved a lot of the hearing, did great. And then 1 month after starting wearing the CI, he already started to show improvement. AZ Bio was 73%. And then, SSQ went up a little bit, 6.16. I'm not sure I would call that a dramatic difference. But 3 months later, all the other variables are going up. So CNC hit more than 56% or 50%, which as you remember, I was saying that's considered clinically a good result in many ways. AZ Bio is up to 75% and 51% with SNR. So 1 year later, I see him back, and now he's not wearing a CI. And all the numbers dropped again. CNC back down to 16%, and AZ Bio dropped to 40%. So this is one of those cases where, use and improve, and you disuse and you lose. And these teenagers, do we consider a closer surveillance for higher risk age group? I would think yes, but again, that motivation is what comes into play. So putting it all together, the unilateral hearing loss in children can impact behavior, scholastic, speech and language development. It is associated with listening fatigue. I didn't get into this too much. It's just starting to come out in the last year or two that people are publishing on this. But listening fatigue is when the child is just exhausted just from listening. So if you can think about a child sitting in a classroom, the teacher says something, and by the time that the child figures out what the teacher said, the teacher's moved on to the next thing. And the child is playing catch up and trying to listen. And by the end of the day, they're exhausted. They're napping, they're tired. And it's beyond just, being a child and just normal tiredness after school. So this is coming up more and more. And I didn't bring it up too much, but there's more to come with that. And then the quality of life impacts we saw. This is a quote from Helen Keller that I think hits true for some of this. Blindness cuts off from things, but deafness cuts us off from people. There's this depression, social isolation, all these other things that I didn't mention, but we can see that with some of these children with hearing loss. So the evaluation should be tailored based on patient characteristics, time of diagnosis. There's so many variables that come into play, but there's some generalizations we could do with this. All patients should be recommended for ophthalmology and genetics. These are just basic JCIH guidelines, but I hope I showed you some reasons why I would do it anyway. All infants, if they have a hearing loss, they should get tested for CB within 3 weeks of birth. MRI and CT really depends on the type of hearing loss, the age of the patient, if there's anticipated surgery, and all these other variables. Lab should only be done when there's clinical suspicion. There's no reason to order a bunch of labs for no reason. Management, it's a thorough discussion of options, close monitoring speech and language, audiological follow-up. I do refer for speech and language assessment for all patients because I think there are subtle deficiencies that we miss in spoken language. This is not I think, a routine practice at every institution, but a lot of institutions are leaning towards neurocognitive evaluations and speech and language assessments on these children. And then I use it to track milestones in these younger patients because the classic finding in the past was these children fail, they have speech delay, they're doing fine, and they fail hearing at school. And then, they come in at age 5 or 6, right? This is before newborn hearing screening started picking up these children early. They would come in with speech delay or they, fail screening at school. So the speech and language issues can start to manifest over time. And I use the speech and language assessment to keep track of these milestones in these younger patients with the hearing loss. Referral to audiology, absolutely, to think about all the hearing rehabilitation options. We talked about the FM systems for all patients, hearing aids cross, and anything else for mild to severe, phoning curds and CIs for severe to profound, depending on the status of the nerve and motivation of the patient and other variables. The CI is showing promising auditory outcomes and quality of life benefits, but there's so much to learn from this. And I think that's where the future of the research is going to go. We need to carefully assess the imaging, the auditory testing, comorbidities, family, parental motivation, duration of hearing loss, age, psychosocial. There's so many variables that come into play with this. And I think there's so much to learn in this arena. Management, you have to talk to the whole family with the entire team of professionals to come up with the right plan for that family. Shout out to the HIP team who have been instrumental in a lot of this research and working with me. So that's it. I do have all my references if you guys eventually want that.
Thank you, Dr. Anne. That was such a fantastic, comprehensive review on this topic of unilateral hearing loss in children. And I mean, personally, I'm very impressed by how a lot of the landmark articles that you referenced were published by you and our team here at the Cleveland Clinic. So congratulations. Yeah, so we'll take some questions. We have a lot of time for questions. I think Dr. Bryson has his hand up.
Yeah, hey Sam, good morning.
morning.
Congratulations on a great talk and truly being a content expert in this field. I had just a couple curiosity things. When I was in training, our program, our leadership really used to tout all of the sort of grassroots advocacy at the state level, and it seemed to me that the access to care and the detection abilities really varied state to state. What's your big picture assessment of where do kids fall through the cracks in terms of getting to you and your team most quickly, or is that a thing of the past? Or like what's your sense for, what's the opportunity loss for the youngest little kids not making it in after a failed screen or getting screened or what have you?
Oh, Paul, that's a great question. There is definitely healthcare disparities when it comes to access to care for hearing loss in children. So we looked at this, I'm blanking on the paper. Once they actually make it into the system, they do fine. So the study that we published, essentially, there's a paper that came out of UH looking at CI access for Medicare patients versus normal, and they found equal access. And similar, our paper, when we looked at our population, they had similar access to speech and language, and they had similar access to treatment. But that's when they get into the system. Obviously there is literature out there that shows distance to the hospital, socioeconomic variables like maternal income and all these other variables do play a role in getting to the system. Once they're in the system, we're all over it, right? And we do great with getting them the services they need and making sure that they follow up and things like that. But if you talk to our audiology team, Carmen, I think she's on here, but she would argue that even when they get in the system, we sometimes lose them because there's only so much we can do to keep track of all these little guys running around, and making sure they come back for follow-ups. And we're good. We're not great. There's so much to be done with that. So thank you for that question.
Swati?
Hi, Swati.
We can't hear you, Swati. Maybe we'll go on to Brandon.
No, always impressive, Sam. My question is more of just where are we at in the, I think one of the biggest things that drives your volumes here or hampers the volumes is our ability to provide hearing aids to patients with Medicaid. This is for you, I guess, and for audiology colleagues. Like, what do we have to do to just commit to that and be done with not being a hearing aid provider for Medicaids? We say we want to serve and serve the local community, but I think until we decide to commit to that funding of pediatric cochlear implants or hearing aids, because that's really what drives so much of this hearing aid volume, this cochlear implant volume, we're going to be chasing other centers because we're going to send them out and they're never going to send them back to us. So
we need a hearing loss coordinator. And I know we talked about it, but we need somebody to literally keep track of these patients, because that's what I was saying about, we do a good job, but we're not perfect, because there are some kids that leak through and we don't get them back until it's too late. Sometimes, these duration deafness, our team, usually we start getting hesitant around 7, around 10 to 12, we really don't want to implant them. Sometimes we get them too late. We don't have the manpower, I think, individually to sit there and try to keep track of all these children, and that's where I think we could win by getting somebody to help us.
Agreed.
So Swati put the question on the chat. So she said, great talk. Was just wondering if you have an idea of where we are with universal newborn CMV screen testing. Sounds like it has become the norm in some states.
Yes. So Boston, I think, does it. Utah, I want to say, does it, because they were part of the study with congenital CMV treatment. I think it's still going on, and I want to say they just finalized some of the data the past year. We started at the Cleveland Clinic doing it, but it's definitely not statewide. We need to do better. So I've been working with PEDS ID over the past couple of years, and at least we've started to do it within the Cleveland Clinic neonatal and newborn nurseries. If they fail a newborn hearing screen, they should get screened. There's no reason not to.
Dr. Kaminsky.
Hey, Sam, thanks for the talk, but your mouth moves faster than my brain can receive.
Uh-oh.
I know, I was going really fast. I wasn't supposed to end like 10 minutes early. I'm sorry.
So you may have said this and I just didn't catch up to it. Is the field so new that we don't know what happens to these kids in adulthood?
Yeah. It's really new. Like I said, we did that systematic review before we looked at our patients to see what's out there, and there were only 120 kids that they were reported in literature with the CI for unilateral hearing loss. So we're just now starting to see, but we don't even know what happens to them in the long term. How many will use them 10 years from now?
Right, so that would be the thing that you said about a coordinator to track these kids. That would be a great opportunity to have some sort of registry to have longitudinal studies on our patients.
100%.
So Alan, we have your support for a care coordinator funded through HNI to manage this. I like that.
Yes,
Thank you
through
for
your
your support.
pediatric philanthropy, Brandon.
Excellent.
All those kids with money.
Philanthropy just means we don't care enough to fund it through our own service line.
Paul?
Yeah, just a follow-up to that systematic review. Somebody else is talking. Oh, wait.
Just talking about it sounds like in some other states there's been some
We can hear somebody. Can you mute yourself? I don't even see anyone else.
It sounds like there's been some
We can only hear like bits and pieces of that question. I wonder if they can put it in the chat.
Yeah, I can wait if you want. It's okay. Can you hear me?
I can hear you, Paul.
Okay. Yeah, Mike, just a quick clarification question. So you did the systematic review, and you said there were only a small number of kids that had data that was, valuable, right? Um, is that just a quality issue in terms of the data and the tracking? Or, I mean, what's your sense for how many kids have a cochlear implant that if they had good data, you could have included in your analysis? Because it seems like a small number. Like I believe there's more kids with CIs than that, right?
All the studies that we included everything,
Yeah.
except case reports. But, people are collecting these patients. And now, I know Ohio State, Oliver Adunca has about 40 to 60 patients that he was writing up. So just now we're getting these higher numbers because before we used to battle with insurance to get them approved. So, I had maybe less than a handful that I did before 2 years ago. And now I have like 20 or 30. So I think those numbers are real. I bet there's more, but people are not publishing because all these are small series of like 7 patients or 10 patients. Is it worth, like, I would be embarrassed to publish a series of 10. So
Yeah. No, understood. Okay.
Yeah, just kind of going along that question, that comment, it seems like there is an opportunity for, like what Alan said, like a multi-institutional registry or, like a big database to combine all those patients and analyze their outcomes. And I guess in order to maximize that opportunity, you need to standardize some form of protocol in terms of, objective and qualitative outcomes.
yeah, no, that's absolutely a struggle too. I mean, we used Iowa, which is a massive program, and Oz and Virginia Mason, like Seattle Children's, and we came up with 40 in 2 years. So it's because we're being careful about just not implanting everybody, right? So and then we worry about the ones that don't have good outcomes. So and we don't know who are going to get good outcomes. So even like these short duration kids that look amazing and you're like, this is a home run, they're going to do great, and they're not using it. They're non-users. So yeah, it's and then in terms of standardizing protocols, yeah, I mean, I think almost all the institutions will do CNC when age appropriate, or some of the sentence testing when it's age appropriate. So there's some standardization to that. But in terms of the pre-op and getting them to the OR, you're right, there could be more standardization in testing protocols and things.
All right. Anybody else? 7:58. What a great grand rounds. Thank you so much. And hope everyone have a great day.
Thanks, guys.